Good morning or good afternoon and welcome everyone. Thank you so much for joining us on our webinar today for wound care and xylazine with our presenters, Dr. Nicole Gastala and Michael Huyck. Today's webinar is brought to you by the Great Lakes ATTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The views expressed in this webinar are the views of the speakers and do not reflect the official position of DHHS or SAMHSA. The ATTC network uses affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. We do have a few housekeeping items for you all. If you have any technical issues, please individually message me, Alyssa Koala, or Jen Winslow in the chat, and we would be happy to assist you. If you guys do have any questions specific to the webinar, please put them in the Q&A section of the toolbar, and we will take some time at the end of the presentation today to get those answers. The recording and PowerPoint will be made available on our website within the week. If captions or live transcript would be helpful, please use your Zoom toolbar to enable them. You will be directed to a link to a very short survey at the end of today's presentation, and certificates of attendance will be sent out to all who attended today's session in full. If you would like to stay connected with the Great Lakes ATTC, follow us on Facebook, check out our LinkedIn, our YouTube, and our podcast channel. And I'm super excited and honored to hand this over to our presenters, Dr. Nicole Gastala and Michael Huyck. Thank you both for being here.
Good morning, everyone. I'm Dr. Nicole Gastala. I am family medicine and addiction medicine and the medical director at IDHS Super, which is the Substance Use Prevention and Recovery Division of the Illinois Department of Human Services. And I'm also lucky enough to do my clinical role in a federally qualified health center system in Chicago. And I am really grateful to have Mike Huyck here today, who can introduce himself. And we're going to present today on wound care and xylazine. One of the things that I do want to let everyone know before I pass it to Mike is that there are going to be potentially some triggering images in here. These images are, again, for to help the healthcare workers on this call sort of see the different types of wounds that they may see and how to care for them. So yeah, just a heads up, if you need to turn off your video at any time, completely understand. So I'm gonna hand it over to Mike.
Hello, I'm Michael Huyck. I'm a family nurse practitioner. I work in the FQHC here in Chicago, Mile Square Health Center, which is a super cool, busy location that allows us to test new modes of care. And so I specialize in doing primary care, but specifically for integrated primary care for folks with substance use disorders. Most notably opioid use disorder in our location. And so I'll be talking about the wounds today. Am I able to control these slides? Let me see if I hit this. Oh, okay, very good. So we'll go into it, and then Dr. Gastala is going to get into the xylazine part, and we're going to tag team this. So people who inject drugs, generally they're just at an increased risk for wounds and skin and soft tissue infections, and the prevalence of wounds and abscesses and such are very high in this population, can be as high as 20%. And some things that I want folks to take home from this presentation today is that not all wounds are skin and soft tissue infections. Some folks just have chronic or acute wounds, and so they don't really need to be treated with antibiotics, but just need careful debridement and dressing selection. And the reason for this is because most of them are chronically colonized with bacteria anyway. So we're going to be drawing a distinction between what are like injection-related wounds and ulcers, as a result of the cutaneous complications of opioid use disorder versus what are skins and soft tissue infections and how we treat them. And so, this is a really great population to treat because most of them are ambulatory, are very motivated to take care of their chronic wounds and abscesses. So, with a little bit of patient education, these folks are really able to care for themselves quite effectively if given the proper tools. So we want to make sure that, if we are clinicians, that we have a way to offer support services for wounds and these infections for these clientele, as well as, if we're in a position to admit people to different programming, for recovery and everything, that we're not barring folks who have chronic wounds, which are very highly prevalent in this population, from our programs, because then we're going to really miss out on treating a very large portion of this population. And if we don't address the main risk factors for these wounds, such as, the injecting substances, then we're never going to heal them. So we got to get them in the door. So just some things about me. I am not a wound care specialist, but I play one on TV. No, I started, I have 10 years of inpatient experience with the VA. During my time at the VA, I worked anywhere from emergency room to ICU, and I covered a wound care service as well, inpatient and outpatient. And so I was typically, when covering the wound care service, placing wound vacs in the OR, things and so on and so forth. And when I was a nurse practitioner school at UIC, I worked in harm reduction facility here as a volunteer and did my DMP project, where the prevalence of wounds was a really big issue for folks who were running the harm reduction service. So one of the things I was doing over there was trying to find a way to effectively treat and educate the clients about their wounds. This was back in 2018. So that's just a shout out to COIP. And so some things we'll cover today: what causes these chronic wounds, how much they cost, their symptoms, where are the complications, and how do we treat them. So just like some background, the first hypodermic syringe was invented in 1851, and as early as the early 1900s, there are some early reports of injection and syringe sharing. So there's probably wounds back then too, and abscesses and everything in between. And what are people injecting? Because it's important. This affects why folks develop wounds. Well, heroin, pharmaceuticals such as those listed, cocaine, methamphetamine, or any combination thereof. So there's a lot of individuals who may inject multiple substances. And where do people inject? Anywhere there's venous access. And so, most common upper and lower extremities, but of course, like many folks here, we've encountered people who are also injecting in the neck. I've had people injecting on the breast, beneath their eye, and things like that, under their tongue. So generally anywhere there's venous access, depending on how difficult it is for a client. So it's really important to get a good history of where people are injecting, because that is going to determine where they're more likely to develop a wound. And it was a claim from back in 2018. This is when we had the crocodile in the supply, which was a synthetic opioid that is common like in regions of Russia and post-Soviet states, and it did make an appearance here for a little while. And we were dealing with some acute wounds back then. But some of these clients, they'll tell you if something's up with the supply. It's very common. And so when we're looking at wounds, we need to look at how they heal. And so there's 4 stages. It's just like you or me skinning our knee. First the body tries to close it off. Hemostasis, controlled bleeding. And then there's an inflammatory phase where the body's sending white blood cells and everything to clean up the mess and any type of potential pathogen. And then once it does that, the body will start the proliferation phase, where it starts to close off the wound and start to, the granulation tissue starts to reform and fill that wound in from the bottom out. And then eventually it closes off and it gets into the remodeling phase, which is a prolonged phase that could last up to a year, where, you get the strengthening of those collagen fibers in the skin. And so the issue here is wound healing can become arrested in any one of these phases in this population, just really depending. And so really, if things are not getting debrided, if folks are manipulating their wound, if there is a wound infection, poor nutrition, all these things can affect, prevent people from advancing from one stage to the next. And so, how do people get infections in their wounds? Well, poor peri-wound, peri-injection hygiene. So if people are injecting, they don't have access to alcohol, chlorhexidine, they're not washing the site, of course, they could introduce an infectious organism. This is why harm reduction is very important. Also, contaminants, xylazine, things like that can contribute to the wound. Heroin is very acidic in itself. Depending on what part of the country, what part of the world you're in, certain heroin supplies have to, you have to use an acidifier in order to inject it and cook it up. And so, sharing injection equipment, all these things can increase your risk of a wound or a soft tissue infection. And so, what are some of like the reasons why? So, maybe somebody develops an abscess, they tried to self-treat it, and they keep trying to drain that thing, and then it develops into an open wound. Or maybe they extravasate some of this heroin or fentanyl or whatever's out there nowadays, xylazine mixed in there into the subcutaneous tissue. Does it get into a vein? It gets under the skin. It's very acidic. Some of these, the heroin that's been studied, street heroin, at least on the West Coast, of pH anywhere from 2.5 to 4, which is similar to vancomycin. Think about what happens when that gets under your skin in the hospital, right? So, just destroying surrounding tissue, the body, mounting an inflammatory response to it. Heroin and other substances are meant to be injected into a vein where they're diluted. And so if they're not, it really increases your risk if it gets under the skin of having a wound form. Cocaine, methamphetamine, even xylazine to some extent, we believe can cut off peripheral circulation and cause tissue hypoxia and necrosis through that mechanism. And many people have wounds from many different causes, like all those above. And so some of the risk factors for developing a wound: skin popping. So as folks' venous access, if they are injecting, decreases, a lot of individuals will resort to other modes of injection. So injecting heroin under the skin. Of course, like I said, it's acidic. There's a lot of contaminants. There's cutting agents. Getting this under your skin is not good for your body. And so, when we see clients with this, we'll see a lot of these kind of dime-sized ulcerations and scars under the skin, which is very characteristic of skin popping. And wounds are very, very, injection-related ulcers are very common in this population. Hygiene, like we discussed before, whether there's a plethora of research of whether people clean and disinfect prior to injection directly affects where they can end up with an infection or a wound. The more you inject, increases your risk of a wound or an infection as well. Using multiple sites. Lower extremity injection is also greatly associated with the risk of developing wounds, as well as skin and soft tissue infection. And so just to kind of give an idea like what the prevalence looks like, and this might not be characteristic of everyone's practice here, but looking in harm reduction facilities, at least, and the folks who access services there, can be anywhere from like nearly 20% or higher, in the range of 20 to 30% of folks who have an active wound or abscess or some type of cutaneous issue related to opioid use disorder. And you can see even on the West Coast, some of these studies, that prevalence can be even higher than that. And so this might not be true for everybody who's working maybe in a primary care setting and things like that, but you can expect like a high prevalence of wound and soft tissue infections in this population. And so, year over year, and there's not too much different recently, but the hospital admissions for this are going up. They are very expensive. Just to one, county alone, over a 6-month period, you're looking at, $12 million and, $4,400 for an admission. Like that's cheap, right? These can be much higher than that. We know a lot of folks will stay in the hospital for a week or more on IV antibiotics, and depending what, if they have osteo or any other resulting complications, those would be very expensive for our system for not addressing it. And just looking at the clinic I was at prior, when we first opened like a medical outreach service in the syringe exchange, where we were trying to do Suboxone, medication-assisted recovery, basic primary care, STI treatment, things like that. When we did a survey, out of the total visits that we had over the first year, 200 visits, we're looking at a quarter of our entire volume was just based on wound care, people coming in for wound care and abscess care. And so, it's important to draw a distinction between wounds, between soft tissue infections, because they are not the same. Not all wounds are infected. Most of them are all colonized chronically with bacteria. And so, wounds don't all need antibiotics, okay? And the Infectious Disease Society of America has some guidelines on this. They don't recommend just doing bacitracin and things to wounds because it breeds resistance. And 10% of the population has an allergy to polymyxin, so it could actually make wounds worse and more painful and uncomfortable. And so we want to carefully find a way to debride these wounds, manage the exudate, and find a way to get folks dressings to keep them covered. And so the type of wounds that we'll see, injection-related ulceration. So, whenever somebody comes in with a wound, we always want to ask them, like, when did this start? When did you first have this? And the answer would be like, oh, I had an abscess and maybe I self-drained it, or I got it treated in the ER and it never closed up and the skin died off and opened up. Or somebody might tell you, kind of like in the prior slide, I injected and then I noticed this wound, form shortly afterwards. Something is not right with the current supply. It's different. People are people, and so there are organic causes of wounds as well. So people end up with venous insufficiency, venous ulcers, arterial wounds. So just because folks inject drugs doesn't mean that that's necessarily the cause of their wounds. We also have to be cognizant of the other problems that can cause wounds as well in those differentials. And so injection-related ulcer, kind of like I mentioned, this can come from like heroin supply that needs an acidifier, like folks who are maybe injecting black tar heroin, which is common on the West Coast, or even in Europe where that supply needs to be cut with an acidifier, gets under the skin. More commonly here in Cook County in Illinois, in the Midwest, with this increasing prevalence of xylazine, it could be related to the cytotoxic effect of that. Other things, quinine, citric acid, things that are added to the supply, whether folks are injecting mixtures of cocaine and heroin, because the cocaine is vasoconstrictive, can choke off local blood supply. These are all considerations in what can be causing a wound to form. I think I'm handing it over to you for a little bit, Dr. Gastala.
Yep, that's right.
All right. Talk about xylazine.
All right, thanks, Mike. So, injection-related ulcers, so xylazine. So, xylazine has, we'll talk a little bit about where it's at in terms of Illinois, but it has, been in many areas of the country for longer, including Philadelphia and Puerto Rico. It's a central alpha-2 adrenergic agonist. It's mainly used, right, as a veterinary tranquilizer and sedative really since 1962. And what it does is it reduces the release of norepinephrine and dopamine in the central nervous system, which then ultimately causes sedation, muscle relaxation, respiratory depression, and hypotension. It was first reported as an adulterant in the heroin supply in Puerto Rico in the early 2000s. So that's sort of where it sort of first popped up. And then when it came to the mainland, it's really been seen in Philadelphia, found around 2010, and it's been associated with increased risk of fatal overdoses and acute wounds. So there's a couple things as to why. So in terms of the overdose, naloxone will not work to reverse it, right? It's not found alone, right, in the drug supply. Xylazine itself, it's going to be xylazine plus fentanyl, xylazine plus heroin, xylazine, heroin, benzo, whatever sort of mixture the individual is buying. And the Narcan, you should still give it because it will reverse the opioid component of it, but it's not going to reverse the xylazine component. So that's where it can be a little bit more challenging, right? So you got to support and watch that patient afterwards. So again, still give that naloxone. And then in terms of how it feels, a lot of our patients will say that it helps give their fentanyl legs to make it feel like heroin used to. So sort of last longer, help with that, sedative effect of it. You're going to see individuals sort of have that, more heavy nod around 20 to 30 minutes after, lower heart rate, blood pressure. They may complain later of dry mouth, and then the skin ulcers is, one of the biggest trademarks that we've been seeing with this, and that can be, complicated, right? They can require complicated wound care. The areas may become, large. There'll be dead skin that needs to be sort of debrided. They're not necessarily infectious, right? But they can become infected. So again, it's the start of it is because there's decreased, blood supply to an area, and then, causes that area, to die, and then open wounds, which then can then lead to risk of infection. So one of the most important things is, if the patient's able to, not have that in their supply, obviously not picking at the skin, and then keeping the wound as clean as possible with soap and water. So yeah, that's sort of the, some of the background for it. In terms of what we see in Illinois, this is sort of why we've been talking about it here, and likely in some of the states that you work in as well, is that the number of fatal overdoses has increased related to xylazine. So those who are xylazine positive, we haven't seen it throughout the whole state. It's mainly, in the Cook County northern area, but we do see it, distributed in the western and then southern area of the state as well. In terms of age groups, it tends to impact almost all age groups, a little bit less in the less than 25 in terms of fatalities, and then has really impacted our non-Hispanic Black population, white, and then still Latinx too. So the highest percentage of fatalities occurred in the non-Hispanic Black individuals, which is, tends to be our highest overdose rates in the city as well. And again, it's found with other substances, right? So when those autopsies were done of the individuals in 2022 who had xylazine positive overdose, they also had 100% had an opioid in it, right? So it's being mixed with that. It's not just being sold separately. Many had cocaine in it. Many of the individuals also had alcohol, benzos, and a psychostimulant. About 9.2% of the fentanyl-involved deaths in Cook County and 7.6% of the fentanyl-involved deaths statewide are xylazine positive. And it's, again, most commonly found mixed with an opioid. Most of our patients have polysubstance use, so that's where you can sort of detect it in other drugs as well. And the challenge with it is that the alpha-2 adrenergic receptors are also found in peripheral tissues, but the alpha-1 are more prevalent, right? And this alpha-1 agonism is actually what results in that vasoconstriction. So they're thinking that the xylazine causes injection site tissue hypoxia and skin necrosis through that local one alpha-1 agonism. But the challenging thing is that wounds can also occur independent of site injection and have been reported in those who insufflate heroin and not ones who inject. And so that's where it sort of then becomes distributed somewhere downstream, and then, causes this sort of local hypoxia and skin necrosis. All right, I'm going to hand it back to Mike.
All right, now everybody can hear me again. So kind of like we were talking about earlier, is that like really our clients are the experts on what's out there. And so, at first I was thinking like, oh man, xylazine's been around since the early 2000s. It's been around since 2010. It's, prevalence is increasing. But now we're just seeing the wounds. Is it really causing these wounds? And like a lot of the clients insist that something is really changing out there. And this is just an example of one of the clients who has chronic wounds that also tested positive for xylazine, told me about the current state of the current drug supply. So, one of the things, like I said, when we're looking at what are the risk factors for wounds, that we would need to ask clients is whether they're injecting into their wounds. This is a type of wound, like we mentioned earlier, wounds that come from skin and soft tissue infections, and there's injection related ulcerations. There are also individuals who will harness a chronic wound for the purpose of injecting heroin or fentanyl. I use those terms ubiquitously at this point, into the wound. You know, kind of like we mentioned with the stages of wound healing, there is like a lot of like hypergranulation tissue in these healing wound beds. They have a very rich blood supply. So just like skin popping, if you inject an opioid into the wound, you're gonna get very quick absorption. And folks that do this will kind of describe that it's almost as good as getting it into a vein. And so one of the reasons I was looking into this is because like back in 2019, I was having a lot of folks with wounds that no matter what I threw at it, I could not get them to heal. And then I started asking people like, you know, a little bit more about where you're injecting. And then a few folks told me they were injecting into their wounds. So I went ahead and started asking more of my clients, you know, whether they inject into those wounds. And sure enough, about 50% of the clients who had these chronic wounds were actually injecting heroin into those wound beds. And so, yeah, this is a very serious risk factor and something that we need to be addressing, and we have to address it in a very respectful way, like because it's a very personal thing, you know, because a lot of times people are very embarrassed about injecting into their wound beds. And so, like I said, this is very, very prevalent and it's not commonly screened for. So it's just something we need to be on the lookout for as clinicians, whether people are injecting into the wound itself. Venous stasis ulcers. So, you know, for folks who have a prolonged history of lower extremity injection, what happens is these acidic substances that are in the heroin, other drugs themselves, they eat away at the integrity of those valves inside the veins, and so they become incompetent. And so what we see is like a very large cohort of folks in their late 20s, early 30s that have advanced venous stasis disease. They have that characteristic, you know, pitting edema. And so this is something we need to be on the lookout for, because one, increases their risk of blood clots, and it decreases wound healing time, increases wound healing time for lower extremity wounds. And of course, the treatment for venous stasis is different. It's compression-based therapy. You know, sometimes folks can inadvertently miss a vein and hit an artery. And I've seen this happen specifically in the hand, where the radial artery has been injected to, and then you just get this burst of like shatter emboli that goes into the distal circulation of the digits. And sure enough, you know, I've seen the black fingertips, what people thought maybe was frostbite, but it's actually the distal peripheral circulation being cut off. So, you know, also, I've had traumatic amputations in clients due to femoral artery necrosis and things, and coming in with gangrenous lower extremities. So that's another very large risk factor. Is we want to make sure we're screening for people whether they're injecting in their groin, because it's very, very dangerous. It's a blind stick. That's what we call it, because you cannot see a femoral vein. So inadvertently accessing the femoral artery is very, very common. But then, of course, people are people, right? And people who inject drugs also have medical problems independent of injecting. And so there could be some peripheral artery disease in this population as well. So other things we need to screen for. And so, you know, besides the injection-related ulcerations, ulcerations related to xylazine, the venous disease that's resulted from prolonged injection in the lower extremities, or injecting into chronic wounds. Obviously, there are many different types of infections. We're going to go over a few of them, okay? And the thing is, what decreases infections? Harm reduction. We want to make sure that we're teaching people injection site hygiene, getting them alcohol swabs, so on and so forth. Make sure they have access to clean syringe supplies. So abscess, you know, hopefully people are familiar with this, but if not, this just looks like a giant pimple. It's red, it's angry, it's boggy, it's fluctuant underneath. It's usually from staph or strep bacteria that's resident on the skin. And so how do we treat this? We drain it. We lance it. Of course, if it's not over a major artery and it's not too big to handle in our office, it doesn't need a general surgeon, okay? And so incision, drainage, antibiotics, packing. Cellulitis, non-purulent infection, and so, you know, you'll see that margin of erythema that's, you know, expanding up an upper or lower extremity. People might say the skin feels like it's on fire. So this is treated with antibiotics. This is definitely an infection. Pyomyositis. So kind of what we talked about earlier, there's intravenous injection, there's subcutaneous injection or skin popping. For folks who have difficult venous access, sometimes we'll see, in addition to skin popping, people will engage what's called muscling or intramuscular injection. And so, somebody can come in with a swollen, painful upper or lower extremity. It may look like it's cellulase, but really, we want to get a good history on them, find out what their injection practices are, because in fact, there could be a deep abscess or deep space infection within the musculature, and, which needs to be sent to an emergency room. These folks need IV antibiotics, and simple x-rays and things, we could see subcutaneous gas with this condition. So definitely pyomyositis needs to be on the differential. Anthrax. So there's no reported cases of anthrax related to heroin injection in the Chicagoland area or in the Midwest for that matter, as far as I know. Most of this has been isolated to the West Coast, it's been isolated to countries in Europe, like Great Britain, being that in Europe, most of the heroin supply comes from Afghanistan. And so that heroin supply is commonly transported on livestock that, would cause anthrax exposure. Also on the West Coast of the United States, where there are sometimes more crude heroin supplies, such as like black tar heroin, things that are also transported via livestock through Sierra Madres and things in northern Mexico. So that's where these cases have been logged. Necrotizing fasciitis. So this is a picture from a medical resident who did this case study on necrotizing infection. So this medical student was in a cadaver class, and he inadvertently nicked himself with a scalpel that he was using on the cadaver, and this is the necrotizing infection that ensued. And so, what's really important to note about this is if somebody points to an infection, and you want to ask them, when did this start? And so if the answer is this started an hour ago and it's already halfway up their thigh, so that's a reason to get somebody to an emergency room very quickly. It's because necrotizing infections, they expand extremely quickly from the source. So like I said, whenever we're getting a good history, this is something that should be on the differential. Botulism toxin, soil-borne pathogen, kind of like we discussed earlier. No known cases in Chicago, mostly isolated to the West Coast, countries in Europe where heroin supply has been transported on livestock. So this is more common. Black tar heroin, which used to be much more prevalent, like in the early 2000s, 90s, 70s, and 80s, is a pretty crudely purified, form of opium, and it's commonly, not made in the lab and everything, and so it could be made like on farms and things like that where there is exposure to these, soil-borne illnesses. And so this particular case, they suspected this client was intoxicated on opioids and under the influence, but really it was a botulism infection. So like I said, really not common here in Chicago at all if it's ever happened. But depending on, maybe we have somebody traveling through and they brought their own supply with them, and it is a supply from Europe or black tar and things like that. So just something to be aware of. So I got this picture from Sir Charles Bell, which kind of documents what a tetanus infection was. Same thing, soil-borne illness. Okay. West Coast countries in Europe like Great Britain, Ireland, Scotland. And so this is a pretty serious infection. If somebody has it, it's pretty obvious to diagnose, and hopefully nobody encounters this. But yeah, if you have somebody who's like rigering, severe muscle spasming, seizures, things like that, tetanus infection can definitely be happening, but these are really supply dependent, not prevalent here in the Midwest if they've ever happened at all, but there's something to be aware of as we clinicians tend to travel. And then, like, how do we manage these different infections? Well, the Infectious Disease Society of America has a really good algorithm. And so if anybody's ever curious and you want to work this into your clinic policies, for treatments of SSTIs, they have a really good algorithm for how to go about doing that. And then also we have to consider differentials, right? People are people, people have medical problems, even people who inject drugs. So family histories of skin cancer, basal cell carcinoma, folks with maybe untreated HIV, Kaposi sarcoma, also things that we've diagnosed in my clinic in younger clients with opioid use disorder, such as scleroderma, pyoderma gangrenosum, some of these cutaneous there are complications of inflammatory bowel disorders and things like that, Crohn's. People are people, right? And they have medical problems, so we need to consider the differentials outside the realm of the result of injecting as well. And so now let's talk about what we're going to do when we see a wound. So the first thing we're going to do is we want to assess a wound, okay? So you want to know how big it is, how it got there, how long it's been there, and then what we need to do next. Photographs tell a million, will tell a story in a million words, right? So anytime you're sending somebody out for a referral, maybe to a dermatologist or a wound care specialist, if you could get them to one, photos are very important. Length times width times depth, okay? So we always want to take a look at how big it is, how wide it is, how deep it is. What type of necrotic tissue do they have? This particular client has a mixture of necrotic tissue. There's like some yellow slough. It obscures most of the wound bed. There's some black eschar. Is it loosely held to the wound bed? Can you dry sweep it out with a piece of gauze, or is it really stuck on there? How much of that beefy red granulation tissue in a wound bed can you actually see? Versus how much of the wound is covered with necrotic tissue. Is there granulation tissue present? And what does that granulation tissue look like? Is it beefy red, which is characteristic of like good circulation, or is it dull pink, white, friable? Is there odor, smell? Does it look like there could be some circulatory compromise? Edges, are the edges attached to the skin? If not, is there a cavity going under the skin? Can you probe the wound? Is there tunneling present? That's a concern because those areas will need to be packed in order for them to heal properly. What does the skin look like around the wound? Is it intact? Is it dry? Wounds tend to have exudate, and that exudate leaks out from a wound and can eat away at the skin around a wound. So we want to know what the status of the skin around a wound is, and then how much drainage is there? Is there just a little bit? Is there a whole lot? That's going to determine what type of dressing you need to select for this client. And this is a client that we treated at my clinic who volunteered his wounds. We thank him very much. And so, if you can't see a wound bed, that's a problem because it's not going to heal. The presence of necrotic tissue will prevent a wound from healing, from pulling at the margins, from regranulating. And so you need to debride it, unless if you have concern for gangrene or arterial wounds, in which case we're not going to debride them because that could be very dangerous. And then how do we debride a wound? Okay. There's some like really non-painful ways to do it. Collagenase is an enzymatic debridement agent. It's been around since like 1987. It's still $200 for a 30-gram tube, and it's very rarely covered by any insurance plan. So it's very commonly used in the hospital, but getting to it outpatient can be difficult. Surgical, obviously, we would have to have resources to get people to an operating room or a wound care specialist that can take care of it. There can, for folks who can get a little bit more training on the side, you can do some conservative sharp debridement. I do that from time to time if folks will allow me to, because it can be painful and even to the best of your ability of anesthetizing the area. But you could do a lot with a dermal curette, which is the only thing I use because it has a sharp end and a blunt edge. And so it could be good for kind of scraping off some loosely adhered stuff from time to time. And then there's autolytic debridement. Most of what everyone's going to do here is this technique. And so the body will debride itself as long as we adhere to a few guidelines, okay, which is necrotic wound tissue that's dry needs to be rehydrated. Okay, the body will send white blood cells, from our immune system. Those blood cells naturally secrete collagenases, peroxidases, things that will eat away at this necrotic tissue. And then, it takes some time, but it will rehydrate itself. And then with a little bit of manual debridement with some gauze and cleaning these wounds out over weeks to months, we can get the wound beds pretty clear. And this is a painless way to do it. And this is going to be the way that most folks will choose to do debridement. Okay. You could do wet to dry dressing. It's not recommended. It's very painful. And then, if you can use a wax curette, like for an ear, you could use the blunted edge of a dermal curette. You can use gauze. These are ways, if you have some loosely adhered slough, it's well hydrated, that you can just kind of gently sweep this out of the wound as you're doing irrigation, dressing changes on a weekly basis, but also the client can do themselves at home. And so as far as what dressing like we can give people, there are 20,000 different companies that all say that their dressing is the best. The problem is, there's synthetic skin now and everything. There's collagen containing dressings. A lot of these dressings are very expensive. And so I don't use them, and I don't really have too much experience with them outside the hospital setting. And I work with a mostly Medicaid insured or uninsured population. I can't use them. I can't get them approved. And so on the very basics, like we need to have dressings that will absorb exudate, maintain a wound moist environment, and not adhere to that granulating wound bed. Okay. And we need to be able to do this for folks who have limited financial resources so they can actually afford to change their dressings. This is one of the more expensive things that you'll see on a cheap, simple formulary, calcium alginate. It's made from seaweed. It absorbs a lot of exudate, and it like turns into like a gel. Okay, and so this is great, like if you have a cavitous wound, to pack it, because when it comes out, it'll come out like a wet noodle. Like I said, it turns into a gel when it rehydrates itself. So it's very, very, it's very comfortable for clients to perform a dressing change. I use these. I will cut them into ribbons to pack wounds with them as well. So they're pretty versatile, but they're one of the more expensive, $1 to $8 per unit, depending on what brand. Basic hydrogel, like I mentioned earlier, if you have a wound that has very dry necrotic tissue without like any drainage, you're going to need to rehydrate that necrotic tissue. And so, these are very simple. These simple thing to use. It's kind of like aloe vera and glycerin based, and it just donates some moisture to that dry necrotic tissue. And then you can start to soften it up, loosen it up, and start sweeping it out of the wound bed. $2 for 1.5 ounces. Collagenase, like if you can get a grant or you could get them to give you some, but I have cyber bags and I haven't been successful so far. This is really, really effective stuff. It doesn't really hurt people. It's pretty painless. And it's, with 2 to 3 dressing changes and this applied, you can really get a lot of necrotic tissue out of wounds. So it's a great product if you have access to it and your clients can afford it. There are some manufacturer coupons available as well. These are what we call screens, or my clients coin that term. They call them screens. And so what we know as a wound contact layer, very important thing to have in your formulary, because if you put an absorbent pad over like a wound, it'll adhere to that wound bed. And then when you pull that off of a wound, it's going to hurt somebody, and it will probably pull some of that newly granulating tissue off with it. So we want to make sure that we have a wound contact layer that's in contact with the wound bed, and so that prevents a traumatic dressing changes and doesn't disturb the healing tissue. And so, this kind of looks like a screen. So the effluent can come through that screen onto a secondary dressing, and then when you remove them together, it doesn't hurt them. For folks who have these venous insufficiency ulcers, kind of like I mentioned earlier, compression-based therapy is the evidence-based treatment for them. These multi-layer compression wraps are what are most common for treating lower extremity venous ulcers. And so I'm telling you, if you have a podiatrist like in your network, these are the folks to get linked up with. They mostly handle everything below the knee, including lots of these like venous chronic ulcers. Their podiatrists are excellent at debridement, especially with diabetes wounds. And the debridement, like across the board, the principles of debridement relatively hold the same. And so they're a great resource, podiatry, to kind of, if you want to learn, you have a chance to spend some time with them. A lot of what I've learned is from podiatrists. I don't really use these in my practice. I tried to roll it out, but I have a large unhoused population. So folks were getting them placed on and not coming back to have them taken off because they need to be changed 2 to 3 times a week. You know, if you have a heavily colonized wound that needs to, you know, that needs to be decolonized, you don't want to apply topical antibiotics. We want to use an antiseptic, antimicrobial, and really the most evidence-based treatment out there for that is povidone iodine. You know, and so basically diluting this in a 1-to-10 ratio with saline, and then applied to the wound for those 30 seconds will kill pretty much anything that's on there. And so if you have like a very malodorous wound that looks like there's some type of superficial wound infection, doesn't need systemic antibiotics. When you're doing irrigation at wound changes, if they don't have any underlying thyroid disorders, this can be a really effective agent to use, and it's not cytotoxic. The issue with chlorhexidine and a lot of these other wound antiseptics is that they're cytotoxic to this newly forming tissue within the wound bed itself. Things like Dakin solution, which is bleach, you know, this will kill the new tissue. So it's not necessarily needed, but povidone iodine is one of the best things to use if you have a very heavily colonized wound that needs to be treated. And so kind of like what this is, I'm just going to go through like a quick dressing change in the clinic with me, what it would look like. So I had this client come in. This is an injection related ulcer. It also was being injected too. Okay. And so one of the first things I did is I looked at the quality of the skin around his wound, and I noticed that there was this margin of erythema. There was some moderate drainage coming out of the wound bed, and wounds are like a baby. We need to keep them dry. We need to keep them covered. We don't want the wound to be dry, but we want the skin around it, to be moisturized but not waterlogged. Okay. Think what happens if you sit in a hot tub for 5 hours or whatever, you're going to come out like a prune with skin issues. It's the same thing that happens to the skin around a wound. If the effluent from the wound gets onto that healthy skin that's around it unchecked, because there is the presence of collagenases and peroxidases and these other things that the body sends there to break down the necrotic tissue, it will break down the good tissue around the wound as well. So we really need to really hammer home, we have to protect the skin around the wound, or else that wound will just continue to grow from the margins in a very shallow way. Okay. And so Vaseline, diaper cream, zinc oxide based ointments, all these things are really cheap. You can get them at the dollar store. We want to make sure that we're heavily applying these barrier ointments around heavily exuding wounds. Okay. Moisture associated maceration is a major wound complication. So somebody just mentioned in the chat that they use skin prep. Skin prep, it can work, but it usually kind of comes in these little squares, and it's much more expensive. You could get a lot more bang for your buck with Vaseline and diaper cream. So that's why I go with that. What do we use to absorb drainage? ABD pads. ABD pads, they're 5-10 cents a piece. I could get thousands of them on the cheap. You don't want to place these directly over a wound bed because it'll adhere to it when you take it off, but they're great for absorbing a ton of drainage, and they're extremely cheap. Okay. And so just some things to take. I think I missed a slide here. Well, maybe we got cut short on a few slides. Anyway, don't ever place this directly over a wound bed, okay? And so just some things to take home, which is, always assess your wounds, length times width times depth. If you have necrotic tissue, you got to find a way to get rid of it. So autolytic debridement, for most of us, for those of us with a little bit more training, conservative, sharp, mechanical debridement. If you have a lot of biofilm, odor, superficial infection, get it out of there. Debride the necrotic tissue out of there. Use the povidone iodine to treat it. If you got dry necrotic tissue, you got to remoisturize it. If you have a ton of exudate and drainage coming out of a wound, you have to manage that, or else it's going to grow. Protect that skin around the wound. Never put something on the wound that will adhere to the wound bed. And of course, you want to mitigate any issues that can be contributing to the wound itself. Okay. And okay, good. We're back with the slides. Okay. So here we go. We have our wound. All right. It looks very dry. What do we do next? We applied that barrier ointment. Go ahead, rinse out your wound with some saline and everything, clean it out real good. Okay. The thing you want to keep in mind is with agents like hydrogel, medical honey, if there's no necrotic tissue, don't apply it to the wound. If you apply that stuff to a wound bed, it's gonna burn. Okay. Medical honey is a good thing to use. It's much cheaper than collagenase. I'm not going to plug any brands here on that. There are many different types, but it helps kind of osmotically draw moisture into the wound bed and rehydrate necrotic tissue. Okay, and so here we are. I went ahead, I applied all of my barrier cream around the wound to protect it, and then I placed a screen or a wound contact layer over the wound bed. It's a pretty superficial wound, about 0.5 centimeters, so I did not pack this wound today. Okay, and then once we applied the wound contact layer, the next part I did is I placed an absorbent pad over it. And so, like we said, we protected that skin around the wound. We have a wound contact layer so that the drainage could move through it onto a secondary dressing or ABD pad. Okay. So, $1 for our tube of barrier cream. Okay. 50 cents for a wound contact layer and 10 or 20 cents for our dressing here. Okay. So we're still on a pretty cheap dressing change here. Okay. And then I secured it with an elastic band, okay? Elastic bandage, a Velcro one. I don't like using tape because tape tends to peel off good skin with it. And also with these elastic bandages, a lot of the clients just bring them to the laundromat or, when they do laundry at home, just wash them and reuse them. So it doesn't cause local tissue trauma, and they're really good to be reused for our clients. If you have a cavitous wound, we have to pack it. Okay. And so calcium alginate works good for that, or gauze, but the thing is we want to do moist to moist dressings. Okay. If we are having to pack wounds with gauze, we want to make sure people are moistening those gauze with sterilized water or saline. If they could have safe tap water, they can boil at home, they can use that, but you don't want them to wait until it dries out to remove it, or else they're just going to keep traumatizing the wound bed. Gauze are old school. They're very cheap too. You can get a whole truckload of them for $100. And so they're very versatile in how we use them. But for those of us who are coming from a hospital setting, we may have seen those orders. Wet to dry was the thing since the 1950s. They used to have wound lights that they would put on, to dry it out in the hospital. So we don't want to do that. We want to make sure that people, they may need to change their packing 2 to 3 times a day to keep it moist. Okay. And this is just like a sample of like a very typical simple formulary. And then when I get off today, I'll send the PDF with some quick wound care tips for clinicians, as well as this formulary, in case you were looking for something like, what can I stock in my office? That way you can have this resource of, this is the cheapest stuff out there. I've been honing this for the last 5 years. So, cheap is the way I do things, because it's just more resources for more people. And just kind of like going forward, we're really changing people's lives. Like a lot of times folks, even when I was working in the syringe exchange, who are not ready to enter treatment for substance use disorder, being able to tackle a medical issue like a wound was a bridge to create trust in this population. And sometimes, throughout that months-long process of addressing their wound care, their wound issues, having them come in weekly for dressing changes in supply runs, we're really able to make progress and then finally get people into treatment. So, what we're doing out here, if we get treating these wounds, is really, really important. It's changing people's lives. All right, go forth and heal those wounds.
So I know that that was a lot of information, but the good thing is that you're going to get the slides and those handouts. And just like I said, like sort of in the chat, is that For those of you who work sort of on the front lines, right, either in harm reduction or if you work in substance use treatment programs in ERs, obviously ERs have a lot more resources, but for substance use treatment programs, just sort of thinking about like, how do you expand the scope of what you can do to really positively impact that patient population the most, right? And you're going to be the first line, and a lot of times patients have had pretty negative experiences with healthcare systems. And so you may be able to, start the treatment for some of these wounds, particularly the ones that Mike was talking about who are not infected, but just more chronic, right? And that need sort of debridement and appropriate dressing changes and support for that dressing changes. That will be sort of, your sweet spot where you can really help support those patients. And then if you notice that they start to smell different or look different, and concerning for infection, at that point, hopefully the client trusts you enough that they'd be willing to go to the ED or their primary care doc to go and get that next steps of treatment. So just sort of thinking about that. Also, partnerships that you can make with other organizations that can come do wound care at your facilities can be really, really helpful for infectious disease. There's a lot of opportunities to treat, Hep C, HIV, as part of, that treatment package for patients to, help them live their best lives.
Thank you so much, Dr. Gastala and Michael. We did have a few questions that came through. Do you guys have access to that Q&A? They're quite long questions. Or I can read them for you.
Now I see them. Okay,
Okay.
sorry, I was looking at the chat. So can someone clarify the Illinois Xylazine positive fatality slide, please? Is xylazine not being injected but being mixed with alcohol too? Or is the slide highlighting that because they are finding the drug during autopsy, it's just an indication that people are using multiple substances at the time of overdose? That's a really great question. Likely, individuals are using multiple substances. It's not that xylazine is necessarily being mixed with alcohol, like physically, but likely that the individual is, insufflating or injecting, and then also, drinking alcohol. It's what, was found during the autopsy, which is that sort of toxicology report. So that's likely probably what was occurring in these situations. If that doesn't, make sense, let me know. And then my question is regarding treatment. A lot of the clients I'm interacting with explain to me that they know xylazine in the supply and they know they need to get their wounds treated, but they simply cannot stay at the hospital long enough because of going through withdrawal, leaving. The pimps were too long, not able to keep up with the treatment plan. What is your recommendation for this, helping to assist with like at-home wound care based off of what you said? So yeah, at-home wound care is kind of hard because that means that the patient's plugged in, you have to order it, you have to come to their house if they have, it assumes that they have housing. So I think the best thing would be to train up your team members, right? Get nursing out to the, to your facility or out, on mobile units, or, tent units, whatever you may have, to really be able to do that. Some hospitals you can develop partnerships with who will agree to start treatment while the patient is being admitted. And so that's, I think, really important to know where those locations are and having like a tight partnership with those hospitals. We used to have prior to COVID, a street med outreach team, and they would carry a pager. And so they would go out, med students, residents, faculty would go out and do street med outreach. When one of their clients was in the ER, they would meet them in the ER so that they would then see a familiar face, be able to like help support that patient and like, again, help with some of those fears that they have, because it is awful, right? Like to be in withdrawal and then have this wound that you're, having to care for. And wounds, depending on the stage or what they're like or what needs to be done, may be, pretty uncomfortable. But so it is a really hard discussion to have. But I would say the more that you can have these supplies out in the field with you to use, as well as having your team members get training to do sort of basic wound care and help the clients, would be sort of your best bet. And then, moving to different levels of care, as needed. I don't know, Mike, if you had any other thoughts on that.
Yeah, so the best folks at wound care, I'm just gonna like our nurses. This is something that we learn in school, and for those of us who are coming from medical surgical background, working in ICU, we're doing post-surgical recovery. Like nurses just generally have a lot of experience in wound care, and it's really good to have a nurse on your team. There are like professional certifications that nurses can get, wound ostomy certified nurse, WOCN. And so if you have one of those working in your local hospital system, those are good folks to partner with. Having a very simple formulary of these items that we discussed in here, just having gauze, wound contact layer, ABD pad, some barrier creams, a little 120 ml bottles of saline, things that you can give people. Like my average cost for a week of dressing changes for a client is $21. How do I pay for this? With grant money. It's tiring. I've been writing wound care grants for 5 years to keep this going, but it's just something that needs to be done. There's a question of whether opioid settlement money at the state level can be utilized for this as well. But the most important thing, kind of like was mentioned in the question, is folks having issues regarding to treatment adherence. It's treating the addiction, right? Like we're not going to heal wounds if we can't get folks to stop injecting. And so really like aggressive underlying treatment of the substance use disorder is the most important thing. And look, not everybody is ready to engage in treatment. And in some instances, this wound care is palliative. And and it's unfortunate, but that's just one of the realities of the situation out there. So really just having a good relationship with nursing schools, people who do wound care, getting in with a local podiatrist that has experience with lower extremity wounds and doing some debridement training, looking at how they're addressing wounds, having access to basic supplies. These are all like really good ways to start. And then of course, like, being able to link people with care to get them into treatment, to get them into methadone program, opiate treatment programs, getting them on buprenorphine, stabilizing their addictions. Because, like I said, we're not going to heal the wounds if we can't get folks to stop injecting. So that's really the priority.
Yeah, and that sort of leads into that next question, or one of the questions that Jody asked was, when a client tells you that they're injecting into their wound, can you do anything besides educating? Would you treat the wound differently, knowing that they're going to continue to inject into that wound? And I think you sort of summarized that you do the best you can, right? So.
Yeah, and so for that is, as clinicians, when we're who are working in addiction, we always want to focus on the harm that's coming to individuals and not the act. And so, really just educating people like, hey, this could introduce infection deeper below these, subcutaneous layers of skin. This increases your risk for osteomyelitis. This could result in an traumatic amputation, which I've seen multiple times. Like really, sometimes folks, like if we just focus on the potential harms that could come to them, that is very concerning to them. And this addiction, it's a war against the brain, right? And so sometimes it's enough to override that pathway for people to consider getting into treatment. And so that's really what we want to do, is just build a relationship with this client who's wound injecting. Hey, I understand that you can't stop right now, but you want to. Let's continue this conversation. I want to see you back weekly just for a wound check and dressing changes and to get supplies and build that relationship. And then, like I said, in some instances, like this is palliative, like we're not going to heal all of them and cure everyone, unfortunately.
And then question, is the withdrawal longer for xylazine than opiates? I think it depends on the opiate and the length of time that someone has used. I did find a case study uh, on a hospitalized patient actually with wounds who was using opioids and xylazine, and they did manage her xylazine withdrawal with a combination of, it looks like, dexmedetomidine, I can't say that, phenobarbital and tizanidine, and then transition to clonidine. So it does, seem to be there. I haven't had a ton of patients, share that sort of experience yet that they've had that. But it can definitely be possible. I think most of what they're going to feel in terms of that withdrawal is going to be sort of pretty severe anxiety, restlessness, and then that dysphoria, right, that they can have. And you're not going to see, it doesn't look like you're going to see like the seizures you see with alcohol or benzo. So I'll put that case study in the chat.
I just want to address Abby once, the question that's in the chat regarding more advanced wound training, and so that's kind of like, it's just like with addiction treatment in general, like moving into primary care, or like used to be kind of siloed, like among specialists a long time ago. It's the same thing with wound care. Like wound care clinics are like mostly located in hospitals. And if you're not a safety net hospital and those hospitals are run by various groups and the groups don't accept Medicaid, a lot of the clients where the addiction issues and those wounds are really prevalent can't get access to those services. So by us like offering just basic services and access to supplies and things like that and trying to get this done in our office-based visits, we're really kind of de-siloing the wound care mystique out there and streamlining that process. And so it can be hard to get a little bit extra training. And so my recommendation for Abby would be like to find a wound ostomy certified nurse who's working in local hospitals, see if you could shadow them for a day. And specifically like podiatry, kind of like I was saying, like they are often treating a lot of these lower extremity ulcerations, have really good debridement techniques, can teach you about like how to anesthetize a wound properly. Many of the wounds you will see will be on the lower extremities anyway, the majority of them. So it's a really good resource. And there's just a lot more prevalent podiatry practices that accept many different types of insurance. And so I've had to spend a lot of like free time on this, but I've had really good success working with the podiatry community and would highly recommend it.
And there's also a lot of like different professional societies that will put videos like on YouTube, right, or different platforms to sort of share different techniques that they have for wound care. So that's always, another helpful venue to, get that, it's good to have the hands-on experience and then, get some of that additional knowledge and education too.
We have another question that asks, have you encountered clients that kept an open IV line to avoid injecting directly to wounds?
So yes, I have only two in my whole entire career. And I'm not going to say what their professional background was. But that's extremely uncommon. It's extremely uncommon. Like most folks will not encounter that. Where we encounter that nowadays are folks who have dialysis catheters that may be manipulated for injection. And of course, like maybe folks who leave the hospital against medical advice with a PICC line or peripheral IV still in place for the purposes of that. I don't know. That's a question that might be a study, but that's to avoid injecting. Like if we had a prescription heroin program in this country, it might be something we could discuss, but as a harm reduction method. But it's you most likely will not run into that. It's not prevalent, but it does happen from time to time.
Yeah, Abby, I see, what you're saying, and it makes a lot of sense. And the thing is sometimes And if we think about like the regular or like in the general community, right? Family members help all the time and they may not have medical training or loved ones or friends or and you know your team may be that loved one, right, for that client. And so you can provide, you know, with just a little bit of training. It's if you can get someone to go to, a hospital or, but sometimes you can't. And it's important to be able to sort of, again, meet them where they're at, wherever they're at. And, basic, wound care and helping them care for that can be, really helpful.
Well,
So I
thank
just I just dropped a few things in the chat, the basic wound care formulary, which hopefully we could just get out to an email with everyone. And then some wound care tips for clinicians as well, just if you need a quick guide for your desktop.
Yes, thank you so much. I was just going to address that, Michael, that you just dropped those. Jen did drop those in a little bit earlier, but I will be following up via email with those handouts. And the PowerPoint is a larger filed PowerPoint, so you can find our PowerPoint on our website along with the recording this week. I'm trying to make sure we got through all the questions. There was a couple that came through in the chat. So if we did miss any of your questions, please put them in the Q&A. But as I don't see any more questions coming in, I do want to give a few reminders. Jen, thank you so much for putting those in the chat again. Please, before you go, please take the 2 to 3 minutes to fill out our post-event survey. Again, the slides and the recording will be found on our website within the week. Certificates of attendance will be sent out via email to all who attended today's session in full. And then we do offer a wide variety of trainings throughout the Great Lakes region. So check out our Great Lakes ATTC website along with our Great Lakes MHTTC and our Great Lakes PTTC. We have a lot of great resources out there as well. So we hope you guys found value in this wonderful training. And thank you so much, Dr. Gastala and Michael, for being on here with us. Would you like to
Thank
say
you for having
anything
us.
before we go?
No, thank you everybody for tuning in and learning about these wounds, and hopefully we could start to make a dent here.
Yeah, I agree with Mike. Thank you guys for being interested and caring for, these patients and our patients. It's really, very, very important, again, to help address their whole health. So I appreciate you being here.
Wonderful. Well, thank you all. And we thank you all for joining us today. Thank you again, Dr. Gastala and Michael. And we look forward to seeing you all on future trainings. And please watch for an email from me with additional resources. Thank you all.